Once more, thank you for allowing me to share the experience of Uganda as implementation of Option B Plus is concerned. Just as a background, I think previous presenters have already highlighted the benefits of Option B Plus, and in Uganda, we adopted and initiated Option B Plus in October last year, 6 months ago, and our plan is to make sure that all hospitals in the country, Health Center 4s and Health Center 3s, are actually implementing Option B Plus within the next 2 months by end of June 2013. To date, we have over 1,500 health facilities, that's about 70% of hospitals, Health Center 3s and 4s that are offering Option B Plus, and we plan to reach the remaining 500 by June 2013. We are also surprised that although we did not target the Health Center 2s are really the lower primary care points within the parishes or near the communities. The biggest challenge we have in Uganda is that most of them are white elephants. They are buildings without health workers. But for those who have had health workers who have been able to initiate Option B Plus with support supervision in about 2% of these health facilities. Our plan is that since these are near the communities, we are working closely with the government to make sure that we recruit staff to these health facilities and then be able to initiate these services within these health facilities. Over the last 6 months, we have been able to enroll 27,737 pregnant women on lifelong treatment. This is more than what we actually had achieved in 2012 in the whole year. And I think by the end of this year, we should be able to triple this number. Our approach is also that the sites that we train to offer Option B Plus should be able to be accredited to offer antiretroviral treatment for adults and children. And indeed, over these last 6 months, we have been able to bring 100 new sites on board to provide adult treatment as well as pediatric treatment. The guidance that we have in our country for the rollout of Option B is that routine counseling and testing is provided in all the MNCH settings with the opt-out approach. Is not mandatory. And we have adopted the test and treat approach for all HIV positive pregnant women using 1 pill once daily fixed dose combination. And this is started by the midwives and nurses within the MNCH settings, that is the antenatal care, the labor ward, and postnatal care platforms, as opposed to referring them to the medical specialized clinics. And we also provide ARVs for prophylaxis to exposed infant for 6 weeks, as opposed to Option A, where we had to do this for 1 year, and at a certain time we had to give a mother about 8 bottles of nevirapine syrup, which actually was a bit rejected by most HIV positive pregnant women. Our guidelines also recommend exclusive breastfeeding for the first 6 months, and the majority of women in Uganda actually adopt exclusive breastfeeding, and I think this is common in many developing countries. But we have also advised them to continue with breastfeeding and introduce complementary feeds until 1 year and beyond, especially where the mother cannot afford replacement feeds at that time. We adopted a regional first rollout approach where we are taking a few districts at a time, and the plan is to reach all the districts in the country. We have 112 districts, and we plan to reach all of them by June 2013. I've already mentioned that Option B has also helped us to scale up our ART program to 100 new sites, and we're now rapidly exhausting our waiting lines that we had before advent of Option B Plus in the country. What are the plans for catalytic project? Uganda is a beneficiary of this CEDA grant, and over 2 years we are going to receive $6 million US, and we hope to use this fund for catalyzing our implementation in 19 districts. The selection criteria for these 19 districts, the same as what my colleague in Malawi articulated. And for this particular support in these 19 districts, we are looking at community system strengthening, especially in the area of demand creation, retention into care. And we're also looking at especially our year 2 to divert some of the fundings to meet Option B commodities, and also want strengthening monitoring and evaluation in these particular districts. This is a partnership we're implementing, and government of Uganda is in the lead with other partners that are listed below. This project actually, we kickstarted it this month in Uganda. As far as improving adherence and monitoring intentions, we actually planning to use the concept that is recommended by Government of Uganda, that's the village health team concept, to create demand and also for referring the clients to the health facilities, especially early antenatal care attendants. As I mentioned also, we're emphasizing and supporting the concept of peer mothers, peer fathers that we see to have worked in one part of the country that I shared with you briefly. We also plan to use the family support groups. These are kind of post-users clubs, and these are helping us not only to retain but also to share experiences and especially support issues of disclosure. We're also seeing these groups actually bring men on board because men are also encouraged to join these groups, and so this helps us also to facilitate retention and track them into care. And in Uganda, we are also venturing in mHealth, use of mobile phone, and we plan now to procure, actually we started this last year, for each site we have procured a mobile phone, and airtime is sent to that phone on a regular basis from national level. And this phone is used for tracking mothers, but also is used for monitoring. We now have about 8 indicators on the retention and follow-up that we are tracking through SMS. So sites actually enter data in their phones, and we get a feedback at Ministry of Health on how many mothers have been initiated on treatment, how many have been followed up, how many have followed their appointments, how many are lost to follow up. And then this should cause action for those who have lost follow-up. And for those who do not respond or we can't trace through homes, the ones that actually we do home visitings. Again, Minister of Health is leading this partnership, and it is the one who identified the districts, doing coordination and communication. We're also overseeing the procurement and making sure that the health system and community system strengthening takes place, as well as enforcing quality assurance and monitoring and evaluation. We're working closely with UNICEF, WHO, and the EGPAF in our districts. We also have mother-to-mothers, which is strengthening the community component. And within Karamoja region, we have QAM, which is helping us to scale up this support within the Karamoja region. So as a way forward, we specifically for this particular support, we want to ensure that the coordination and communication is effective. We are signing memorandums of understanding with our different partners that are engaged in this support, and also working out modalities to strengthen follow-up of mothers and their infants, and then strengthening, as I've shared, that we will develop the SMS reporting system that will help us to get real-time data and also make real-time solutions. So I want to acknowledge all those listed here. Again, thank you for listening to me.